Hi, good afternoon. Does everybody need to stand up a bit? No? Okay, all right. I was given the unenviable task of trying to forecast for the future. And I'm pretty sure some of the things I say are going to be maybe just a bit challenging. So I just want to give you the context in which I live. I am the dean of one of the largest schools in the country. We have 820 undergraduates in the major. Half of those are accelerated, half are traditional. We have 8 master's programs and a PhD program, 58 students, about 400 master's students, and a new DMP program in its second year with 35 students. I have 85 full-time faculty. It's a lot of work. Every one of those programs is being challenged on a daily basis of what do you put in, what do you take out. The IOM report, Patricia Benner's come to our place and talk to us. I mean, the faculty are in major fatigue. It's not about money. It's not about resources. I mean, I can throw all the resources, and I think we're actually at the point where we're just ready to blow the whole curriculum up and just start from scratch. I don't really see a lot of lines of resistance anymore between the adult health, med-surg types and the pediatric. People are just like, whatever. In fact, I have said several times on the national level, why doesn't somebody come up with 4 model curricula? Then we can sort of play with those 4. We're being asked to just create, and I think Jan said this earlier, our curriculum at Indiana looks like the one I had at the Medical College of Georgia 35 years ago. Longer than that, maybe 38, I don't know. Long time. And that was a different world. You know, they didn't even invent the immune system till after I graduated. That is the truth. It came out in 1976 in AJN. I'll never forget. I mean, can you imagine? Forget genetics. No. Well, so this is on the other hand, great opportunities. Okay, so I'm just going to throw out some thoughts. A lot of this, my colleagues have done such a nice job of already talking about, so I can whip through it pretty easily. The ones I would really want to sort of focus on, because this is a big thing with me, is 50% of the faculty in our country are master's prepared. And why do I think that's a problem? Because the average age of those faculty are somewhere around 55. They have chosen, what happened, I think, 25 years ago is people my age from, let's say, 55 to 65, we went back and got our doctorates, and then we came back and we had to create jobs for ourselves. Because before that, we were all teaching the undergraduate program. So we came back and we started all these master's programs. Now, I'm sure there was a real need for this, okay, but we started them all. And then we turned around to our colleagues from practice and said, you know what, you're really the clinical practice experts. You come teach now in our programs. And then we loaded them up on students. And they have been teaching ever since. And we did not have joint appointments for the most part. We did not really permit, whatever word you want to use, we really didn't facilitate a lot of room for them to grow and do some joint appointments, et cetera. So really where we've gotten ourselves, I think, as a discipline, we deserve. Because we all bought into this. And I would argue that nursing faculty have, well, frankly, and our colleagues in practice, we have followed the docs one more time. And we have super specialized ourselves to the point where we can only teach this, or we do research in women's health issues after menopause. So I really can't teach in adult health because all I really know is women's health after menopause. Get out. We just can't hire that many people to do this. And the same thing's true in pediatrics. In my school alone, we have people in acute care, faculty in acute care that teach the undergraduate course. We have community peds people who are in the community health department. We have psych mental health. I actually have 2 psych mental health certified. One's doctorally prepared, one's master's prepared. You know what? They're in another department. Do you think they talk to each other? No, not because they don't want to, but because, I don't know why because. But they're in different departments to start with. So we've really gotten ourselves kind of functionally into a bad place to be. And I think we're going to have to, this is part of that blowing it up. And I've heard many people, because we're just sort of tugging at each other. And I don't think it's about territory anymore, seriously. People are just wanting to do something but none of us really have a good sense of where to go. I thought this was interesting. When I read and talked to Anne Marie and read what we were doing, I thought, oh my gosh, now I do feel old, because frankly, we did some of this work back in 1994, 96. Some of you in the room were there in Chicago Airport doing this work. Karen Pridham, everybody knows, I hope, who Karen Pridham is, very incredibly famous maternal infant researcher at University of Wisconsin, who's now retired, riding around on motorcycles. Seriously, if you knew her, she's a tiny little lady. She rides motorcycles with her husband. It's awesome. She actually wrote a grant from the Bureau of Maternal Child Health, and we brought 30 nurses in pediatrics. 15 were from children's hospitals and rural community hospitals with small units, and 15 were from academic, associate degree, that's why it's called pre-licensure, and baccalaureate, from all over the country. And we hammered these out. These are published in this article. I just thought it was amusing that 20 years ago we did some of this. At the same time, SPN was putting out the first standards. I worked on the standards. That was at the end of my presidency, and I cannot tell you how I'm looking over here because all the NAP and the SPN people are over here, how thrilled I was in 2008 to see that the two organizations came together. Because when I was president, we did not talk to each other. And that and this together, this should not happen again. We should not spend another 20 years. I think there's so many good things that are happening right now in terms of the whole basket's overfull. We've got to come up with some new ways, and people are realizing we have to do it together. So, and these were just a couple of slides that talked about, but the notion, the vision hasn't changed. That's what I find interesting. Either has how we teach it, and those two are not the same thing. So, what's wrong with that picture? So, what's changed since 1996? Because there's quite a bit. And again, we're being told we have, and other people have mentioned it, we have to really look across this continuum of care. The demands for interprofessional education are enormous. Now, I find it amusing if I can't get the pediatric-focused faculty in psych mental health, community, and acute care to sort of talk to each other. How are we going to bring in the pediatricians and, the intensivists? I mean, this could be just really a lot of fun. Certainly, evidence-based practice, those words were not used around 10 years ago, and a lot of us are spending a lot of time, I'll share some of that, working with our colleagues in practice, but I fear in many ways nursing is getting very behind on some of this, and I worry a little bit about that, but and not just in pediatrics, although that's really all I know. These new pedagogies, I wasn't surprised at what I saw on the survey about the lack of, I'd call it buy-in and use of simulation, whether it's high fidelity or low fidelity. Frankly, I've got a $2 million lab in my school that I built. Do you know what faculty were the last to incorporate simulations? Our pediatric faculty. So why did I buy that little person who cost $40,000? I don't know. I sometimes ask, why is it? I mean, here you have a dean who's a pediatric person, and yet who sits on a lot of things over at Riley, and it just, I don't know. What I do know, and I have learned, is that change is incredibly hard for people, especially people who've been very successful at what they've done before, and especially when you're asking people to create new visions and new ways of doing things. And that is where having a master's degree for the last 20 years is not a facilitator of this in academe. I'm not speaking about practice here at all. But in academe, it's if you have not gone back to school or kept up with your professional development, then it's going to be very, very difficult to incorporate these things into the courses and that you offer. And this reduction of time in most curricula, we only have them for 60 hours. Well, let me think about that. 75 hours out of the 120 that a baccalaureate degree requires. And like I said, it's the immune system on, that has been, we have to put the informatics, we have to put the genetics, the gerontology. It's just absolutely unbelievable. And yet when you talk, because we are even at this conference, all we're focusing on is content. Now, I don't know about you, but I spend 90% of my time Googling. You ask me a question, my family makes fun of me about this. I say, well, Google it. I mean, who would know? I mean, even things I used to know, I don't have to keep them up here. So I'm like, well, just Google it. Hyperinflation of your lungs? I don't know. I think I could think that through, but. And usually when I Google it, I actually knew the answer, but that's not important. The fact is, it's knowledge. There's too much knowledge, and it's all out there. What students are overwhelmed. They don't know how to access it. They don't know how to, well, they do know how to access it. They don't know how to take what they're looking at, extract, and then create. And you know what? We don't do a good job of teaching them how to do that. Because frankly, I don't think we know how to do it as well. So this is truly a whole new world. Now, what isn't new, but I think someone mentioned, I think it was you, Judy, that mentioned earlier, maybe over at the table, that we really do need to capitalize on. If pediatric faculty were a little bit more assertive, we would talk about this with our med-surg. I don't know, how many of you work with med-surg adult type people? They're tough. I mean, I've worked in 5 universities. They are tough. We peds people, we like to get along, we like to, we just want to go take care of, I mean, really, we're in pediatrics for a reason. Now, there are a few of us that wouldn't be framed as nice and getting along, but most pediatric faculty would rather sort of not, be super assertive. They'll just figure it out, they'll just take whatever's left. Isn't that right? See, I know some people agree here. You cannot do that on a faculty. With the psych faculty, we'll do just that. They will psych you out and figure out how to get what they want without you doing it. The community health faculty will just do what they want. They just go out there in the community, and who knows what they really do. And it's those adult med-surg you're left with. And wow, they just, they just know how to, they have said things to me like, well, adulthood is like 50 years long. Childhood is only 18. Well, that's true, but still. Well, not if you reframe that and you say, you're right, but 80% of the adult illnesses are rooted in childhood behaviors. Then all of a sudden that conversation takes a whole different, tact if you think about it, but we're not used to sort of arguing and thinking about it like that. So here's what I think we need. First of all, I think we need more assertive pediatric faculty, really. And I'm going to talk about how we need to think about that. Because all of our faculty, not just our pediatric faculty, are still so focused on content. We are in the middle at Indiana of a transformation. I have had Patricia Benner come in. We have had the interprofessional Macy's people. I mean, we have just had everybody come in. We've had book clubs, et cetera, and the faculty are really trying very hard. We've had 2 retreats, but when it comes down to it, what are we shuffling content? We're shuffling courses, we're shuffling content. We're not really thinking about, and I shouldn't say we, but, well, it is we. I don't see our graduate faculty around those tables. And this is one thing I'm not letting up on back home, is your PNP faculty, I don't see them even at the table with the undergraduate faculty. Now, our PNP faculty are doctorally prepared. They have to be. And they're also mostly in primary care, but now they're having to refocus their curriculum into chronic care. Why are you not, as a group, or why don't the psych mental health faculty and the community peds faculty and the acute care and the PNP faculty, why aren't they all sitting around crafting that undergraduate curriculum? Because frankly, that is the most important curriculum we have. That's it. It is the basic and the essential, and that is the future of our nursing profession. So I think we need faculty who can give a little bit on all sides. But pediatric faculty should know those phrases, like I just talked about, 80% of adult illnesses are rooted in childhood. They should be looking for similarities. That's the kind of conversations, not about whether we're going to teach, where am I going to teach tetralogy of Fallot? Well, if you happen to have an expertise in cardiovascular peds, that's going to be real important to you to have those 6 hours. Because remember, I remember when I taught undergraduate peds, it took me 6 hours to go through every one of those, cardiovascular, PDA, and not. Why didn't I pick just 2, the most common, and talk about those? And tetralogy is not one of them. Thank goodness, that's a good thing. We also need these disease life cycle settings are just artificial. And I have to say, some of the good news on this is we have new faculty coming to interview who actually could interview in all 3 departments, family health, adult health, and our community psych area. Because the younger generation is not as sort of, they just have their research interest is in one area, but they've had history and teaching in another. They're a little more fluid, or at least that's what we're finding at Indiana, is they can usually interview in 2 of the 3 departments. And we have them do that and then kind of talk to us about where they'd fit next. So I think what we're finding is our department structures are pretty artificial. Of course, they're 20 years old, wouldn't you expect? But also maybe these life cycle setting disease. Like, why do we continue to talk about community health? Why are we continuing to talk about pediatrics? Why, maybe there's other ways that we can. Now, I know all of you, or some of you are sitting there saying, last time we integrated pediatrics out. Well, based on that survey, we really didn't integrate but a quarter of the programs. So we haven't integrated as much out. But even if we did integrate, how do pediatric faculty make sure that those concepts, those competencies that are in the essentials have life made to them in that curriculum? And there's less, we have to have less content. One thing, you remember these quotes all along. I was one time at Children's Memorial in Chicago. I taught at Rush at the time, or maybe I was up in the Children's Hospital, Wisconsin. I can't remember when. But I came for the Galeese lecture, which is a lectureship they have every year. And I remember this pediatric intensive care head nurse saying, at one point in the conversation with the audience, that she didn't care what we taught them in the undergraduate curriculum. She needed nurses who could think. She could teach them how to take care of pediatric critical care patients. That really made an impression on me. It just stuck. And I thought, wow, okay, I actually know how to do the former, but I'm not so sure I know how to do the latter. Because I was never, ever in a curriculum course. And I was never in a how to teach course. I hate to admit that, but, well, no, I don't hate to admit that. I was doing other things like research and stuff. But it's true. I just didn't learn about, they make fun of me because Indiana's pretty well known for its educational scholar research stuff. And I'd say I learned to spell the word pedagogy when I came there. I really, and that's the truth, it really is. Now I can actually define it. But I didn't know that. I don't think I'm that different from other people. Now, I may have a few students who tell you that I challenge them to think, but challenging somebody to think and helping them learn how to critically think is, I know how I've learned to critically think because I had people from my very first clinical nurse specialist mentor when I was in the Army Nurse Corps and I was a lieutenant. And she just grilled me all the time. Well, why are you doing that? What makes you think that? She was doing it on purpose. And that's what made, I was scared to death of her. She was a lieutenant colonel, and she just really, I just recently saw her, and, to tell her thank you very much. You were my first mentor. And she's like, oh, no. And every mentor since did that to me. Everyone pushed me out and said, I need you to do this. I'm like, I can't do that. Oh, yes, you can. So I thought, well, they see something I don't know. So obviously I can. We don't do that with our students. We hold their hands. We give them 132 PowerPoint slides for a lecture, seriously. They all take multiple choice tests because we have to get them ready for NCLEX. So, and every study that I've read of medical and nursing education shows that students who are tested when they come in think more critically than when they leave. Now, that right there ought to be another tidbit none of us ought to forget. And lest you think I'm just picking on academe, now's my opportunity to talk about practice. I'm not so sure it gets much better in practice, to be honest. I not only do a lot of, I'm a consultant to the Research Council at Riley, and so I work with a lot of the staff nurses who are on that council. But I also have the gift of having a daughter who is a pediatric intensive care nurse. She graduated 3.5 years ago from Samford University in Alabama. And I say gift because it reminds me, you know, they talk to you if you're a nurse and a mom. Some of you probably have daughters, and you get the stories every day, you know, and you watch them grow, and oh my gosh, it's amazing. And she is an incredibly supportive, she's at Eccleston Children's in Atlanta, and an incredibly supportive environment. But you know what? About 6 months ago, she says to me, I'm bored. I'm like, bored? Bored? Wow, really? That's amazing. Why? And she said, well, I don't know. I took my CCRN, and I've got this ECMO thing, and I've got this other, I can't even pronounce half the certifications they're doing. And I'm finally okay with parents. Well, you could do a little better than just okay. Didn't go there. Okay, good. Okay's good. But, you know, I'm thinking, wow, she's not the only one. Because I see I work with these young nurses on this research council. And you know why they're on the research council? Because they're bored. And because it's something different and something new but why aren't we, and it's not going to be every nurse, but why aren't we finding a place for those nurses who are like at year 3, pulling them out 20%, and I know staff, I hear this all the time from Linda Everett and Marilyn Cox and everything, but you know what, get over it. Take them out because you'll keep them. You know, why aren't they pulled out 20% time or, 8 hours every other week? Give them a project. Give them something to do. Say like we were all said to, oh, you can do it. I know you can do it. And then guide them, and we do not nearly. So what do? They end up going back to school for a graduate degree. They really don't want to. They don't even know what job they're going to take when they're done. And then they choose an FNP program. You know why? Because they're more marketable. I'm like, you have got to be kidding me. Oh, well, I'm never going to work with adults. Really? That's a good thing, but I don't get it. So I really think we've got a lot of work to do in terms of developing, challenging, et cetera. Well, I skipped over this whole thing, didn't I? But anyway, okay. How's my time? Okay, I got 5 minutes. Let's come back to faculty for a second. And we do have faculty who need a lot of focus on these new pedagogical, I really can't say it that well, strategies. But what we really need is an interface with our health systems. We have just this past year, after a year of planning, now we have an IU health nurse model. Any of you from Rush in here? Rush University? Yeah, the Rush nurse. I've been a Rush nurse. Yeah? Yeah, if you're a Rush nurse, you're always a Rush nurse. And, they had the now nobody, I think, is actually moving back to the old unification model. But we are trying to make this a seamless continuum. And I have faculty who are saying to me, well, I do work at IU Health. I'm a staff nurse on. And I'm like, that's not what they want you to be doing. That is not what those VPs of nursing, CNOs, tell me they want. They want the faculty mentoring the staff. They want them there, helping them do the critical appraisals of the literature and whatever evidence-based practice project they're doing. They want them on the research councils, but they want them in the leadership workshops. They want them mentoring their nurse educators, not as staff nurses. That's really a difficult switch but until we can get to that point, I don't think we're going to change our curriculum very much at all. It's a subtle distinction, and please do not think I'm saying devaluing the staff nurse role by any stretch of the imagination. But if you have a master's degree, what did you learn in it that was different that you can now offer the younger generation? What is all this wisdom that you brought with you that you can share? And I think they're going, I would like to see 100% of faculty, and in my school it will happen before I retire, doctorally prepared. And the reason I think that is very simple. If you got a master's degree 20 years ago, you cannot think the way we need you to think to envision this curriculum. That does not mean you're not a good nurse. It does not mean you're not a good faculty member. What it does mean is you need to shake up your thinking, get more skills, think of things different, take an informatics, certificate program while you're in it. And frankly, I don't care if I shouldn't say if it's in basket weaving, but I don't care if it's in a PhD in education down in Bloomington, or if it's a DNP at Indiana, Southern Indiana, or we have them in Nevada, we have them at UWM. Those are PhD programs. We have 14 of them are in Indiana, and it's costing me a lot of money, but it's worth it. And what they say is, they don't tell me this, but they tell other people. I've never worked so hard in my life, but I am having so much fun. I'm like, really? Good. Okay. So let's bring that back and change it and shake it up. And that's what happened when all of us went to get our doctorates 30 years ago. Remember those years when you were, it was the most, of course we were all a lot younger though. That's a little bit of a different thing. But if they don't want to do that, there's ethics fellowships, there's Sigma Theta Tau maternal child leadership. I see Lee's a faculty member in that. LNAC. Just get out of IU. Go do something, if you're 60 and you don't want to go back for a doctorate, fine. But find yourself an area you can be an expert at. Because then when you come back, I'm going to hook you up with Riley, and you are going to work as this end-of-life consultant. We are going to have some joint connection here, and because you're going to love that because if you're an LNAC certified person, you shouldn't just be focusing on teaching. You should also have a strong practice component. And team-based teaching, and this is about graduate, pediatric, and child health faculty with the undergraduate, and I talk about this all the time at home, and it is a stretch. It is really. But I also think we need the clinical nurse educators in practice and the undergraduate faculty to be teams. And our faculty have to be on their teams, and they have to be on our teams. And we are slowly making that happen. And when it happens, it's magic. So I would like to see, and what we're appointing our first person, and this is not joint appointments. In the old days, we're actually calling them dual appointments to try to get away from the negativity of having 200% jobs, which is what. And I'll tell you, I had one of these. I was an endowed chair at Children's Hospital Wisconsin and a full professor at UWM. It's the best. I've never worked harder in my life, not even as a dean. And I got a lot of satisfaction out of that job. But it made me think about my work differently. I couldn't be setting-based. If I was working with a staff nurse who happened to be taking a master's course over at the college, and I was working on developmental care protocols she was working on, and that's what she was seeing me. Do I count that on my university time because that's the setting, or is it because she's a staff nurse and that's what we're talking? I mean, get out of here. I learned I didn't have time for that. I had to think of my work as a senior scholar, and what did that mean? Not where did it happen. So I'd like to have other people begin to see that, and I would love to have our faculty start sitting more. And we do have about 6 of them now on the different research councils and evidence-based practice steering committees at IU Health. But I'd love every single one of them. And I'll pay stipends, we'll just make whatever. Until we do this, it's really not going to change, because isn't it all about the people, and it's all about the relationships. And this residency, which I've only heard about I've heard about the University of Kentucky residency, and the data just totally convinced me this is the only way to go. So I'm anxious to hear that presentation this afternoon. And I was asked that question earlier, and I was like, there's no downside to a residency. I can't think of it. And if the downside is about money, that's not a downside. If you're going to keep these nurses longer, if they're going to feel more comfortable, if you're going to enrich our faculty, no. Sorry, not going to work. And nurse educators in practice need to view themselves as career builders. They need to seek these young ones out. Every one of you in this room, I'm willing to bet, was sought out by somebody. You didn't say, oh, I really want to go do this, or I think I'd be really good at this. Or, no, somebody came over, tapped you on the shoulder and said, I just told so-and-so about you, and I want you to go do this. And you thought, I don't have 2 minutes in the day to do anything like that. Of course, you looked at that person and said, oh, okay. But it really is the job of, we can try to mentor while they're in the academic setting, but then they go to practice, and you know who mentors them? Each other. And they all just graduated. That's not a good thing. And they need someone a notch or two above. But I cannot tell you how many times I would say, my daughter would ask me a question or something. I was like, how do I know? Just, I don't know, go talk to the nurse educator or your nurse manager or the clin spec, or you've got all those people in that unit. I don't know it just, maybe because I was a nurse and a peds nurse, she would just keep asking me. And I just kept saying, go out there, But it doesn't happen as often. I know it doesn't happen at Riley. It doesn't happen as often as I think we need to have it happen. So I think that's it.